Hey doctors, welcome back to jabstudiesmetfun for medicine part 11. In this topic, like I have already mentioned over here, what are we going to discuss is infective endocarditis, rheumatic fever, mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and hypertension, a bits of that. Now, see, if you want to talk about them, these diseases, they can take even 1 or 2 hours. What we are going to focus is the must-know facts which you should know so that in any competitive exam, you can clear the questions. All right. So without further ado, let's start. First thing we need to know is in infective endocarditis, what is the organism causing it? Obviously, it's going to be a bacteria. Now, what is the most common cause of acute bacterial endocarditis? The most common cause of acute bacterial endocarditis, that is going to be your, very good, Staph aureus. Answer is Staph aureus. Okay. Most common cause of subacute. Now, acute we know that is Staphylococcus aureus, and most common cause of subacute bacterial endocarditis, that is going to be Streptococcus viridans. Very important. Now see, this is a microbiology question as well. If they ask you acute bacterial, that is going to be Staphylococcus. If they ask you subacute bacterial endocarditis, that is going to be Streptococcus viridans. Okay. Now if you have a history of IV drug user are very prone to cause to get infections like infective endocarditis. If they ask you right-sided endocarditis, remember staph is always right. Staph is always right. So remember the causative organism of right-sided endocarditis, that is going to be your Staphylococcus aureus, and the area which is going to be involved is going to be the valve in the right side, that is going to be your tricuspid valve. So right side IV drug user, if they ask you in the left sided endocarditis, that is caused by the organism, that is going to be enterococci. So then clear, most common cause of acute is going to be Staphylococcus aureus. Most common cause of subacute bacterial endocarditis, that is going to be Streptococcus viridans. If they ask you right side, staph is always right. So that is going to be Staphylococcus aureus. Left side is going to be enterococci. If I ask you now, if a patient had an involvement of a valve replacement, so he has a prosthetic valve. They are quite prone to get endocarditis, so that is known as prosthetic valve endocarditis. If they ask you if the patient develops prosthetic valve endocarditis within 2 months, the answer is going to be coagulase negative staphylococcus, that is known as Staphylococcus epidermidis. Very important. The most common cause of prosthetic valve endocarditis within less than 2 months, that is going to be a coagulase negative staph, which is known as Staphylococcus epidermidis. 2 to 12 months, again the same organism is going to be there, that is going to be Staphylococcus epidermidis. Now after 12 months, now this condition is subacute. So remember, most common cause of subacute bacterial endocarditis, that was also Streptococcus. Over here also for prosthetic valve also the answer is same. If it is more than 12 months, the organism which is going to cause the endocarditis is going to be Streptococcus viridans. Now, whenever we talk about infective endocarditis, that is the inner layer involvement in infection, right? So, where this is commonly found, infective endocarditis is directly proportional to the pressure gradient. Now, let us talk about the layers. Before I talk about this, let's talk some basic anatomy and physiology with respect to the heart. Remember, see, you have the left side of the heart and the right side of the heart. How does the blood flow? Blood flows from up to down, correct? So the blood flows from the left atrium when it receives the blood from the pulmonary veins. The blood flows from the left atrium going down to the left ventricle, and after that it will go to the aorta. Same side, it receives from here from superior vena cava, inferior vena cava, and coronary sinus. From your right atrium via the tricuspid valve, it goes to the right ventricle and then goes to the pulmonary trunk. Correct? Now what happens, what you guys need to know is what is systolic and what is diastolic. In simple way, systolic is whenever they're referring to a ventricular contraction. When your ventricles are pumping, whenever the ventricle pumps, the blood from the ventricle goes out to the aorta if it is the left side, and it goes to the trunk, pulmonary trunk, if it is the right side. So whenever there are any pathologies, then we will be stating the facts. Now, whenever the blood is flowing from left atrium to the left ventricle, now the ventricle is not contracting. That is why this is known as diastole, where the ventricle is relaxing. So if the blood is flowing from the left atrium to the left ventricle, the pressure difference between the atria and the ventricle is high. Okay, so that is why if there is any blockage in between the left atrium and the left ventricle, that is known as mitral stenosis. Stenosis means narrowing of the area. If blood goes backside, that is going to be regurgitation. So this is in the left side, so that's why this is mitral regurgitation. Similarly, when the blood flows the ventricle to the aorta, again there is very high pressure difference. Whenever the blood flows from the left ventricle to the aorta, and if there is any stenosis, that is known as aortic stenosis. If the blood goes back from the aorta to the ventricle, that is known as aortic regurgitation. Similarly, in the right side, right atrium to the right ventricle, if there is narrowing, tricuspid stenosis, Blood goes back, it is tricuspid regurgitation. Here also pulmonic stenosis, pulmonic regurgitation. Simple and easy. Now what you need to know is which of these stenosis and regurgitation are systolic and diastolic. Very simple. Whenever the blood flows from the atrium to the ventricle, as I told you, that is going to be, the ventricles are not contracting. So that is why this is a diastolic. So the murmurs which you will hear in when the blood is flowing from up to down, which is in condition of mitral stenosis and in tricuspid stenosis, is going to be a diastolic murmur. Now, whenever the blood is, the ventricle is contracting. Now, if the ventricle is contracting, you can see here, it has three ways to go. One, it can go up. One, it can go down. And if there is a hole between the ventricle, it can go side by side. Correct? So, if the blood goes up, down or side during contraction. So, during contraction means systolic. So, any of these conditions will have a systolic murmur, which means mitral regurgitation will have a systolic murmur. Ventricle septal defect will have a systolic murmur. Aortic stenosis also will have or a pulmonic stenosis will also have a systolic murmur. See, whenever the blood from aortic, the aorta goes to the ventricle, now the ventricles are not contracting, it is relaxing. In physiology, we talk about isovolumetric relaxation. So that is why when the blood is, when the ventricle is not contracting and then the blood goes up from the aorta to the ventricle, that is a diastolic murmur will be there. I hope you understood with this much. Now, why am I talking about this in detail? Because in one slide, I wanted to talk about the physiology, because this is going to come handy in the later on. Now, with respect to infective endocarditis, remember, infective endocarditis is directly proportional to the pressure gradient. Pressure gradient means wherever there is difference in pressure is too much, chances of infective endocarditis is going to be maximum. If you see normally in physiology, the pressure difference between two atria is minimum. Because there is no pressure, there is no much contraction between the aorta, right? The atria. If you see, the pressure difference between the atria and the ventricle is very high. Pressure difference between ventricle and the aorta also is very high. Pressure difference between the two sides also are very high. Now, what you want to know is that infective endocarditis is directly proportional to the pressure gradient. If you ask me which is the maximum pressure gradient, conditions like mitral regurgitation has maximum pressure difference, because pressure difference from the ventricle to the aorta going up is very high. That is why chances of infective endocarditis in mitral regurgitation is maximum. While on the other hand, as I told you, in atrial septal defect condition, the blood, the pressure difference between two atria are very low. That is why chances of infective endocarditis in atrial septal defect is minimum. I hope you understood this with the diagram. Let's talk about now written facts. See the blood flow. If you see, what is aortic stenosis? Aortic stenosis is left ventricle to the aorta. What is this? This is going to be during systole. Aortic regurgitation, blood going back from the aorta to the left ventricle. This is during diastole. Mitral regurgitation is from the left ventricle to the left atrium, and this is going to be maximum and highest pressure gradient. That is why there is maximum chance of infective endocarditis. Mitral stenosis is from left atrium to the left ventricle. This is during diastole. So that's why the murmur you will hear in mitral stenosis is going to be a diastolic murmur. So remember, mitral regurgitation is, you will have the maximum chances of infective endocarditis. Where can you see mitral regurgitation? You can see in conditions like rheumatic heart disease, which we'll be talking about, and also in case of post-myocardial and post-MI. Okay. If you talk about least chances, as I told you, it is going to be seen in atrial septal defect. While if you ask, maximum chances are going to be in mitral regurgitation. I hope this is clear. This is an important PYQ. So we covered a bit of microbiology, about the physiology, as well as right now your medicine. Talking about in infective endocarditis, what is going to be the criteria? See, now to diagnose infective endocarditis, you have some certain parameters. This is given by the criteria which is known as, very good, Duke's criteria. Okay, so it's known as Duke's criteria, another PYQ. Now, Duke's criteria gives you two parameters. One is going to be the major ones which you have to follow, and the minor one. Let's talk about them one by one. In the major, you have three parameters. Number one is going to be, you'll do an echocardiogram. In the echo, you will find vegetations. But this echo is only sensitive to a certain size, below which they cannot find. The size which you should have is 2 mm. The vegetation size should be at least 2 mm, then only it can be detected. If it is less than 2, you cannot detect it. What you can find is, you can find vegetations around the area, like example in mitral area, you can see valve or ring abscess, or you can also see perforations. This is one major factor. Then is blood culture. What you're going to do is, you're going to take 2 tubes, and in a certain 1 hour difference 3 times. Okay, so like example 8 AM, 9 AM and 10 AM. You have taken the tube, you have taken the sample. Out of these 3 pairs, at least 2 should have the similar organism. 2 out of 3 should have the same organism. Then that clears our other parameter, that is blood culture. The third parameter is if a patient is already having a heart disease, and in a pre-existing heart disease, if there is a development of a new onset murmur. Infective endocarditis ka other parameter is that in an already pre-existing heart condition, if you find a new onset murmur, that satisfies the other major criteria. New onset murmur in a pre-existing heart disease because of leakage of blood. Okay, so 3 parameters which I talked about in the major is, number 1 is going to be vegetations. Remember, the size of the vegetation should be at least more than 2 mm. Second is blood cultures. In 3 tubes, at least more than 2 should have the same organism. And third thing is, in an already existing heart condition, you have a new onset murmur. Now, what can be the symptoms of infective endocarditis is, you can see, for example, over here, you're talking about the involvement of the maybe aortic valve over here, okay? So you can see there is vegetations will be there around the valve. If there is vegetations around the valve, along with deposition of fibrin, clots will be there. So this bacteria and this vegetation, they mix together and they start spreading like an emboli. When they ever start spreading, you know the body is now going to react. The body is going to react with the help of, it will start having fever. As the patient is going to have fever, along with this with the help of circulation goes into the spleen. In this spleen, it causes splenic abscess, and because of splenic abscess, you will also have splenomegaly. So the 3 signs which you see in infective endocarditis is going to be fever more than 38 degrees Celsius. You'll have splenomegaly and you'll have splenic abscess as well. I hope that is clear. So this was the major criteria. Let's talk about the minor criteria. In minor, as we already told, you will have fever more than 38 at least in 2 or more occasions. Predisposing factors of infective endocarditis is if a patient has a history of IV drug use, rheumatic heart disease, or dilated cardiomyopathy. Okay, so these are the first 2. Then you'll have the immunological factors. The immunological factors can be remembered with the mnemonic of ROG, where R is going to be Roth spots, which is seen in the fundus. Roth spot is not pathognomic of infective endocarditis. It can be seen in other all conditions. The important other conditions where you should remember Roth spots are, you have to remember ALL. Anemia, leukemia, and lymphoma. Okay, ALL, anemia, lymphoma, and leukemia. This is, I'm talking about Roth spots which are seen in the fundus. This is an immunological factor. O stands for ocellular nodes. Ocellular nodes can be usually seen as in around the pulp of the finger, but also over here, see, it can be found in the palm as well. This is your ocellular nodes. And G is glomerulonephritis, specifically post-streptococcal glomerulonephritis. So these are the immunological factors. Let's talk about the embolic features. Embolic features, you will see here red macules on the palm and the soles. That is known as your Janvey lesions. This is known as your Janvey lesions, which will be seen in palm and the sole. These are embolic features. Then you'll have mycotic aneurysms. Now, whenever you talk about mycotic, the word which strikes is fungus, but this is a misnomer. It is actually a bacterial infection, as we were talking about. Most common acute cause was Staphylococcus aureus, right? So this is a misnomer, and this aneurysm usually occurs in the brain. So it is an intracranial aneurysm, and it is a bacterial and not a fungal aneurysm. Other embolic feature is subarachnoid hemorrhage. Worst headache of my life, thunderclap hemorrhage. Remember that? Very good. And the last criteria which you have to remember is blood culture. Now notice one thing, that in major criteria we had blood culture, but that satisfies our criteria, which is in this more than 2 out of 3 they should be same organism. Over here, if you have 1 out of 3, that comes under minor criteria. So we're done with major. Again, let's summarize right now only so that we don't have to revise it again. 3 major criteria which was there. Number 1 is pre-existing condition may you will have a murmur, you will have vegetations, and third is the condition is blood culture. 2 out of 3, correct? In minor one, you will have fever, you will have pre-existing condition, maybe he has rheumatic heart disease, maybe he's an IV drug user, or maybe he has dilated cardiomyopathy. If you will see immunological factors, remember ROG, Roth spots, ocellular nodes, and G stands for glomerulonephritis. Embolic features, red macules over here, that is going to be Janvey lesions. If you will talk about mycotic aneurysms also, and subarachnoid hemorrhage. Along with that, blood culture, which does not mean the major criteria. These are the minor criteria. So what is this criteria known as? This is known as Duke criteria. Duke's criteria is for infective endocarditis. Now, how can I diagnose with following features? Not all the features can be present in one patient, right? So what you have to see is, for diagnosis, you should have at least 2 major criteria, or 1 major plus 3 minor, or all 5 minor criteria should be present. 2 major criteria, if not 2, 1 major plus 3 minor, or if no major, all 5 minors should be present. This is what is known as Duke's criteria. Now, what is the management in infective endocarditis? Now, see, if you diagnose infective endocarditis, you know that cultures take a lot of time. If you have been in the hospital, it takes at least 5 days in case of a government sector, or maybe 2 to 3 days, right? So what you have to do is, you can't make the patient just chalo bad jo, we'll see later. No, you have to give some antibiotics. The antibiotics which we give without proper diagnosis of the specific organism, that is known as empirical treatment. In this, the empirical treatment is going to be given for gram positive organism and gram negative organism. For the gram positive, we are going to give ampicillin. From the gram negative, we are going to give gentamicin. Now, if in the history we found out that this person is also a IV drug user, in case of an IV drug user, you have to start now, because most of it can be a methicillin, it can be a Staphylococcus aureus organism, which we saw, right? Staph is always right-sided IV drug user, very good. So for that, you will have to start methicillin. Methicillin is, remember, in case of pharmacological technique, it is highly nephrotoxic. If the Staphylococcus, when you did the culture, you found out that this is going to be an MRSA. What is an MRSA? Methicillin resistant Staphylococcus aureus. In those conditions, now you have to give vancomycin. Okay, whenever there is an MRSA, we are talking about pharma PYQs right now. Whenever you are having a methicillin resistant Staphylococcus aureus, you have to give vancomycin. If the guy's luck is very bad and he has vancomycin resistant Staph aureus, then you have to give now daptomycin. Okay, daptomycin, tigecycline, but usually daptomycin is the one which we prefer. Okay, so we talked about the empirical treatment, ampicillin plus gentamicin, and if it is an IV drug user, methicillin. If it is a methicillin resistant, vancomycin. If vancomycin resistant, you'll give daptomycin. So after 2 to 3 days, you got the culture, and then you will give the most appropriate antibiotic for which the organism is sensitive. Remember guys, whenever you start this treatment, the patient will become afebrile within 7 days. But that does not mean that you have to stop the treatment. You have to continue the treatment for up to 6 weeks. Very important. Why 6 weeks? To treat the deep-sided infections. This is also PYQ. So, how do you treat conditions like infective endocarditis? First of all, let us take with an example of a question. You have a child who has a history of rheumatic heart disease. Along with that, he has fever for more than 2 occasions, and on findings, you found out splenomegaly. So you see, few criteria are getting matched up, right? IV history, predisposing feature. You have a minor criteria and you have a symptom as well. Now you cannot directly just see these 3 features and diagnose that this is going to be infective endocarditis. No, after a set of common conditions which are found in the population, only after that you're going to do infective endocarditis. For example, conditions like dengue. In dengue also you can find splenomegaly. So that is why you're going to do an NS1 antigen. COVID conditions also can elicit, you'll see splenomegaly. That's why you'll do RT-PCR. Histidine-rich protein, HRP2, which is done for Plasmodium falciparum, which is malaria. Malaria can also induce splenomegaly. Then you'll say RK39. Here it comes in RK39, K comes first. So remember, by K you'll have Kala Azar. Okay, Vidal will be done for typhoid and sputum sibilant for TB. Even after all of this, when your result is negative, then you will think about infective endocarditis. And what will be the test you will use for infective endocarditis? To find out the vegetations, you're going to do a 2D echo, and to check which organism is there, you're going to do blood culture. I hope you understood infective endocarditis. Simple and easy. Moving on, let's talk about rheumatic fever. Now, there are so many group A, group B, group C streptococcus. How do you know what is the cause of rheumatic fever? Very easy. In rheumatic, you have an A over here. So that is why it is a group A streptococcal infection. Easy. Common age group which is affected is going to be 5 to 15 years of age. What is the history? You will have recurrent sore throats. Now, what is the issue in rheumatic fever that we are so worried about it? Issue is the bacteria has a specific protein that is known as N-acetylglucosamine. This N-acetylglucosamine, the structure is kind of similar to a protein which we have that is known as the M protein. Okay, so now what happens is, obviously if this is a foreign particle, our body will try to fight it. Now the issue is that this, because of the similarity of N-acetylglucosamine and M protein, instead of killing the bacteria, our body starts attacking ourselves. So that is why this is a hypersensitivity reaction, because it is antibody mediated. That is why it is a type 2 hypersensitivity reaction. I hope you understood this. So remember, rheumatic fever is caused by group A. A comes in rheumatic, so this is a group A streptococcal infection. So if you talk about what are the pathognomic features you see in rheumatic fever, in case of the heart condition, you see Ashkoff nodules, which is a pathognomic feature. If you see under high power lens, you will have anti-Schnau cells as well. What is anti-Schnau cells? These anti-Schnau cells are histocytes, and histocytes are nothing than modified macrophages. If you furthermore see this anti-Schnau cells looks like a caterpillar, that is why anti-Schnau cells are also known as caterpillar cells. What I just said, in case of rheumatic fever, you have three pathognomic features. One is going to be your Ashkoff nodules. If you see under high power lens, you will also see anti-Schnau cells, which are nothing but macrophages. In structure, it looks like a caterpillar. That's why it is also known as caterpillar cells. Now, in case of infective endocarditis, the criteria which we were following was Duke's criteria. In case of rheumatic heart disease or rheumatic fever, the condition with the criteria which we follow is modified Jones criteria. Modified Jones criteria. Now, what is modified Jones criteria? Let's talk about it. First of all, involvement of the valve. In case of valvular involvement, you need to remember what is the most common valve. Remember, mitral side is going to be the most common. Then will be the aortic side. After the aortic, the tricuspid side, and the least amount is pulmonic side. So what I told about, if you see, this is the heart, okay, and these are the valves. The most common is going to be the mitral first, then the aortic, then the tricuspid, and the least is going to be the pulmonic, the involvement in case of rheumatic side. Okay, what are the lesions which are found? If you are diagnosing it early, in case of example, if the patient is affected in the early onset, which is remember 5 to 15 years, if the person is suffering in case of an early age, the disease which usually involves is going to be your mitral regurgitation. Mitral regurgitation in case of an active carditis. If you talk about more than 18 years, now because prolonged infection can be there, you will have stenosis, and that is known as mitral stenosis. If now in the question they'll ask you, in case of rheumatic heart disease, which is more commonly found, you have to mark mitral stenosis. If both are mentioned, you'll have to write mitral stenosis plus mitral regurgitation. Remember this, okay? Very important. Now, what happens in the case of rheumatic heart disease is, usually, as I told you, just imagine it's going to be a mitral involvement, most common side. There will be vegetations around the valve. Because of the vegetations around the valve, which was normally this much space, the space has been narrowed. Because of this narrowing, you will have a murmur. As I told you, if it is in the mitral side, the blood is flowing from the atrium to the ventricle. So is the ventricle contracting? No. So this is a diastolic murmur. And this murmur is known as Carey-Coombs murmur. It is known as Carey-Coombs murmur. And this is a characteristic feature of rheumatic heart disease. Characteristic feature of rheumatic heart disease. Okay. First feature was your involvement of the cardiac involvement. Okay. Now in this cardiac involvement, following which you will have next will be your arthritis. Remember, the arthritis which is seen in case of rheumatic heart disease is a migratory polyarthritis. It is involvement of large joints. First your ankles will get involved, then your knee, and then your elbow. So you see it is migrating upside, right? So ankle involvement, knee, and then elbow involvement. Okay. So this is known as migratory polyarthritis of the large joints. Very important, large joints. So for the pain of the joints, what are you going to give? You're going to give aspirin. NSAIDs will be given. Okay. Remember, in rheumatic heart disease, whenever you test, always you have to test for an antibody that is known as anti-streptolysin O. Now see, joint involvement, that also migratory. So one thing which you can differentiate it between is rheumatoid arthritis. Involvement of rheumatoid arthritis, then the comparison. What I want you guys to do is, whenever you're studying, always correlate with another disease which you can usually confuse. Because usually in the questions, out of 4, you will be able to rule out 2, and the other 2 are the ones which you're getting confused. So for those things, take a sticky note, mark it, and keep it in front of your desk. Okay. So over here, I'm comparing rheumatoid arthritis with this. First of all, in rheumatoid arthritis, remember, it is involvement of small joints, and that is bilateral. You will see wrist involvement, you will see metacarpal, you will see proximal interphalangeal joints, but never distal phalangeal joints. You will never see distal phalangeal involvement. Okay. The antibody is going to be cyclin citrine peptide, or there it was going to be your anti-streptolysin O. The management in case of rheumatoid arthritis is, you can give hydroxychloroquine, you can give methotrexate, or you can also give sulfasalazine. I hope you understood this. So out of 2 features, first we talked about carditis. It can be in case of rheumatic fever, pericarditis, myocarditis, and endocarditis. Remember, endocarditis is very specific. Okay. Second, we talked about arthritis. And third thing, we're going to talk about syndrome chorea. Now see, arthritis over here is going to be an early feature. Why an early feature? Because after 2 weeks of onset of sore throat, you can develop arthritis. Okay. While syndrome chorea is something which is known as a late feature, because it usually develops after 6 months of the sore throat. What is syndrome chorea? Chorea, which means is involuntary, like patient is like dancing. Okay, so you'll see involuntary movement of the hand. Patient can come with complaint of poor school grade because it involves the brain. Now, what nucleus is involved in syndrome chorea? Very important anatomy question as well. It is going to be your caudate nucleus. So C for caudate, C for chorea. So remember this way: C for caudate and C for chorea. That is how you remember. They will ask you another PYQ. What is the management of syndrome chorea? Self-limiting, don't do anything about it. Even after, like, a while you're saying they're still not getting treated, then what you have to do? For that, you can give drugs like valproate, you can give haloperidol, but remember the side effect of haloperidol is drug-induced Parkinsonism, and steroids, you'll have Cushing's syndrome. So 3 features done: carditis, arthritis, syndrome chorea. The other 2 which you just have to remember is going to be subcutaneous nodules formation, and along with that you will have the skin lesion, which will be erythema marginatum. So these are the 5 major criteria of modified Jones for rheumatic heart disease. What were they? First was carditis. Remember the most common valve. Remember the diastolic murmur, the Caddy-Coombs murmur. Second is arthritis, migratory polyarthritis of the large joints. Management is going to be aspirin, and the antibody is going to be antostreptolysin O. Third is syndrome chorea. Fourth is going to be your subcutaneous nodule, and fifth is going to be your erythema marginatum. So these are major criteria. Talking about the minor criteria is very simple because it is an infection, so you'll have a fever, and whenever you're having inflammation, 2 things are going to rise. That is your erythrocyte sedimentation rate, and C reactive protein is also going to be elevated. The other 2 P's you have to remember in minor criteria are: one P is polyarthralgia, which is pain, not inflammation, pain, and the other P is prolonged PR interval. I hope now you remember in case of the types of blocks when we were talking about. One was in the first type was prolonged PR interval more than 5 boxes, 200 ms, where rheumatoid heart disease was also mentioned. Okay. Now, how do you diagnose? You remember in Duke's criteria, you had at least 2 major, if not 2 major, 1 major plus 3 minor, or all 5 minors, right? Here it is different. Remember this. The diagnosis requires at least 2 major or 1 major plus 2 minor. Okay. And remember, you have to do antostreptolysin ASO test, this antistreptolysin O titers. What is the management? Remember, aspirins for the arthritis, migratory polyarthritis of the large joints. Steroids can be given for pericarditis, myocarditis. Valvuloplasty can be given for MR. Remember when we were talking about the MR, valvular lesions, if it is a early onset, like in 5 years old, the valvular involvement, the effect was mitral regurgitation. But if it is after 18 years, it is mitral stenosis. So management of mitral regurgitation can be valvuloplasty, but in case of mitral stenosis, it's going to be different. First thing what I want you guys to know is what is the normal mitral valve area. The normal mitral valve area is going to be 4 to 6 centimeters square per area. And what do you mean by severely MS? Severe mitral stenosis is whenever the value is less than 1.5 centimeter per square. Okay, normal is 4 to 6. If it is less than 1.5, that is known as severe mitral stenosis. For severe mitral stenosis, you have another procedure that is known as percutaneous mitral balloon valvotomy. Remember, valvuloplasty for MR. For MS, that also for severe MS, what you're going to do is percutaneous mitral balloon valvotomy. Kindly see very nicely in the question if it is written severe mitral stenosis with severe calcification. If there is calcification as well, percutaneous mitral balloon valvotomy is contraindicated. For that condition, you can't do any repair. The only thing is you have to give a prosthetic valve replacement. When do you give a prosthetic valve replacement? Whenever you have a severe mitral stenosis but with calcification. If there is no calcification, you can go for PMBV. Okay. Now, what is going to be the treatment? Now, along with this treatment, what are the drugs you give? You give injection benzathine penicillin. Now, remember, before giving injection benzathine penicillin, you always have to do an ATD, that is your after test dose, to prevent chances like anaphylaxis, because it is penicillin. Very commonly, you can get a reaction. And after how long you give? Injection benzathine penicillin is given IM, that also deep iron. It is given every 3 weeks. It is given every 3 weeks. And why do you do it? To prevent recurrent sore throats. So it is to prevent. So that is why we'll talk about in community medicine. This type of prophylaxis is known as secondary prophylaxis. Okay. How long do you give this injection penicillin? First of all, it is very painful, but the patient has to go on with it. Remember how long? If the patient just has rheumatic fever without carditis, up to 21 years of age or up to 5 years of diagnosis. Okay, if a patient has rheumatic heart disease but only inflammation, there is no regurgitation or stenosis, that time you have to give for up to 21 years or up to 10 years of diagnosis. If a patient has rheumatic heart disease along with mitral regurgitation or aortic stenosis, now you have to give it to up to 40 years of life or 10 years from diagnosis. Anything which is longer, that is going to be there. For example, if the patient is 19 years old and just 2 years left for 21, then you have to continue it for 5 years. If the patient is like, so I hope you're understanding, any of the two will be there, but whichever is longer. Okay. Now, just now I told you what is ATD, that is after test dose. Why? Because of anaphylaxis. Anaphylaxis is a very important PYQ which can come under microbiology, under medicine and pathology. So if you talk about what is this, that is going to be anaphylaxis. Before talking about anaphylaxis, I want you to know, if a patient has allergy to penicillin, now what can we do? That time we can change our drug to macrolides, and the macrolide of choice for penicillin allergic children, that is going to be your azithromycin. Okay, it is going to be your azithromycin. I hope you understood this. Now, what is anaphylaxis? Anaphylaxis is what mediated? Is it eosinophilic or basophilic? Very good. It is a basophilic mediated histamine release. Because of the histamine granules, there will be vasodilation. Now, what are the symptoms? Very important. Remember, in anaphylaxis, you will have tachycardia and you will have bradycardia. Two very important things. It is ulta pulta, right? So you'll have a rash, wheal, itchiness will be there, bradycardia will, hypotension will be there, tachycardia will be there, bronchospasm will be there because of the bronchoconstriction, cyanosis and stridor. Because of the inflammation, the cause of death in case of anaphylaxis is laryngeal edema. What is the cause of death? It is going to be laryngeal edema. Okay. Next, they'll ask you, what is the interleukin which is involved in anaphylaxis? The interleukin involved in anaphylaxis is very good. Interleukin number 4. Interleukin number 4. If you talk about the treatment is going to be injection adrenaline. Now, this adrenaline is going to be given IM. Remember, each dose of adrenaline with respect to its route is different. So for anaphylaxis, we are going to give an IM injection of adrenaline. The ratio is going to be 1:1000. Very important is 1:1000. It is already in the vial like this. That is why it is undiluted. It is undiluted. I hope you understood the case of anaphylaxis. Next, let's talk about little summary of what are the different conditions. First, we'll talk about mitral stenosis. So see, let us give a so that we'll not try to mug it up. We're just going to use logic so that we'll have a basic understanding and we'll never forget about it. Now, what is mitral stenosis? As we already told, this is going to be the valve. Normally, this is going to be the valve between left atrium to the left ventricle. It is going to get narrowed. That is known as mitral stenosis. Simple. So what happens is, because of this narrowing, the blood which we had to flow from the left atrium to the left ventricle and then to the aorta is going to reduce. So if the blood flow to the aorta is reducing, blood flow will be reduced throughout the body. If the blood flow throughout the body is reduced, that is why you will get tired very often. That is known as effect intolerance. Simple. Next condition, if the blood flow is not going down, it is going to go up. So this, what happens is, then your left atria is going to dilate. If your left atria is going to dilate, blood will go back. Where was the blood coming from? The blood was coming from pulmonary veins. And where the pulmonary vein was carrying? To the lungs. That is why blood will go from the left atrium, from the pulmonary vein to the lungs. That is why you will have pulmonary edema. Because of pulmonary edema, now you will have difficulty in breathing. That is known as dyspnea. So what you will have? You will have dyspnea, you will have orthopnea, you will have paroxysmal nocturnal dyspnea as well. Simple. Now, as I told you that because the blood is not going down, they will be applying pressure in the walls of the left atrium. That is why you will have left atrial dilatation. Because of left atrial dilatation, remember we talked about this, it was seen also in conditions of atrial fibrillation. Atrial fibrillation is twitching of the atria. Basically, there will be no heartbeat, right? It will be around 300 400 like this. Now, because of this twitching, you will have clots getting built. Clots will become to build in this side, in the in below, and because of which now this clots will start getting embolate. That is why you will have conditions like embolic stroke also. So see, because of mitral stenosis, patient can suffer from stroke also. So it's very dangerous, right? Now, because of mitral stenosis, as I told you again, left atrial dilatation is there. Because of left atrial dilatation, you have a nerve over here, the recurrent laryngeal nerve. This is going to get pinched. That is why in these patients, you will have hoarseness of voice, and this condition is known as Ortner syndrome. I hope you understood all the features. One more time, effect intolerance because blood is not going down. Dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Why? Because of pulmonary edema, blood is not going down, so it is going back into the lungs. Left atrium dilates. Because of dilates, there is a nerve over there, that is a recurrent laryngeal nerve, that is getting compressed. That is why you're getting hoarseness of voice. Along with this, because of the dilatation, you will have the clots. These clots can go and travel, and it can go to the head, causing your embolic stroke as well. I hope you understood this. So remember what I told you, the blood flow is from your atrium to the ventricle. This is during diastole. So that's why the murmur which you will hear is a diastolic murmur, specifically a mid-diastolic murmur. Okay, it is a mid-diastolic murmur. So remember, the mid-diastolic murmur which is seen in case of mitral stenosis is going to be a low pitch. For any low pitch murmur, you have to use the bell of the stethoscope. Okay, the small part, right? You have to use the bell of the stethoscope. And the best way to hear the murmur in case of mitral stenosis is going to be in left lateral decubitus position. Which are the murmurs or the features you can hear with the bell? It's also a PYQ. You can hear the S3 sound, S4 sound, mitral stenosis, and a tumor plop as well. What is a tumor plop? Tumor plop is nothing but usually you will have a benign tumor that is known as the atrial myxoma. This atrial myxoma comes and hits the valve, the mitral valve, tup, tup, tup. That is why this is known as the tumor plop. This also is a low pitch sound. That's why you're using the bell of the stethoscope. So S3, S4, mitral stenosis and tumor plop can be heard. What is the investigation of choice in case of your mitral stenosis? It is going to be an echo. Management we already discussed. If it is case of severe is less than 1.5 centimeter, you're going to do a percutaneous mitral balloon valvotomy. If it is a calcified condition, PCMB is contraindicated. You have to give a prosthetic valve. Simple, easy, na? Moving on. Let's talk about aortic stenosis or pulmonic stenosis. Now see, aortic stenosis and pulmonic stenosis is whenever the ventricle is contracting, then the blood is flowing from the ventricle to the aorta or the pulmonary trunk, which means the murmur you'll hear in aortic or in pulmonic stenosis is going to be a systolic murmur. Simple. How do you remember this? You can remember, if you're not understanding the pathology, just remember PASS. You want to pass, so remember PASS. P for pulmonic, A for aortic. Pulmonic or aortic stenosis, the murmur is systolic murmur. Simple. Now, because there is narrowing of the pathway of the between the valve, the trilunar valve is getting narrowed, right? So the blood is not able to flow from the left ventricle to the aorta. Blood is beginning to collect within the ventricle. That's why you're going to have left ventricle hypertrophy. It is aortic stenosis. In case of pulmonic stenosis, you'll have right ventricle hypertrophy. Simple. Important thing you have to remember is that in aortic stenosis, you will have a carotid thrill. You will have a carotid thrill in case of aortic stenosis. Okay. The treatment of aortic stenosis is TAVR. TAVR stands for transcatheter aortic valve replacement. Simple. If they'll ask you which are the conditions where you see aortic stenosis, one is again which we talked about, rheumatic heart disease. In case of old age patients, which will be senile age, and along with that calcifications can happen as well. So three conditions: rheumatic heart disease, age related, and calcification can cause aortic stenosis. Aortic stenosis can induce a carotid thrill. The management is TAVR, that is transcatheter aortic valve replacement. Let's talk about mitral regurgitation. Now I want you to remember, now mitral regurgitation also is happening when ventricles are contracting, then the blood is only going up. So remember, in case of ventricle septal defect also, this is the septum, here the left ventricle and the right ventricle. If there is a gap over here, then the blood will go because of pressure. How is the pressure happening? When the ventricle is contracting. So now I know in case of ventricle septal defect or in case of mitral regurgitation, both the sides are because of a systole during contraction. So this is a systolic murmur. So remember, mitral regurgitation and ventricle septal defect both are systolic murmur, because the pressure is so much that you will hear this murmur throughout the systole. That is why you have to remember this is a pansystolic murmur. Ventricle septal defect and mitral regurgitation both are pansystolic murmur. And on the other hand, aortic stenosis and pulmonic stenosis are just in the start. That's why just in the start, then you will not hear it. That is why this is known as ejection systolic murmur. Okay, remember, aortic stenosis and pulmonic, I'll just write it over here. Aortic stenosis and pulmonic stenosis are example of ejection systolic murmur. Okay. On the other hand, mitral regurgitation and ventricle septal defect both are example of pansystolic murmur. The one going up and the one going side are example of pansystolic murmur throughout. Okay. Next condition is going to be a continuous or machinery murmur. The meaning of continuous or machinery murmur is throughout the time, which is even in systole you will hear it, and also in diastole you will hear it. That is why this is known as continuous murmur, and it's very loud. That's why it is machinery murmur. Two conditions where you have to remember this is going to be patent ductus arteriosus, and the other condition is going to be co-attraction of the aorta. What is co-attraction of the aorta? We have talked about this in detail in pediatrics. Make sure you check that video out. Co-attraction of the aorta, what happens is that there's going to be a narrowing just below the distal part of the aorta, due to which first of all you will have collaterals, but this narrowing which is there is going to be due to this narrowing, blood will not go down. Because of blood will not go down, you will see leg wasting, you will see femoral delay. Over here my pulse will be different, and over in my foot the pulse will be different. Because of the blood is good in the upper part than the lower part, you will see the upper part has warm extremities while the lower part has cold extremities. So that's why this is also known as differential cyanosis. So co-attraction of the aorta, remember collaterals are built, but collaterals are also not enough, due to which you will have femoral delay, you will have differential cyanosis, you will have leg wasting. The investigation of choice is going to be an MRI abdomen. Okay. Patent ductus arteriosus is because of the persistent connection between the pulmonary trunk and the aorta. You will have a continuous blood flow from the aorta to the pulmonary trunk. Okay, here are few pressures with respect to physiology which you should remember. In the left ventricle, it is going to be 120/5. That's why the maximum pressure is there. That is why mitral regurgitation was the maximum chance where infective endocarditis was found, remember. Then in case of the aorta, 120/80. Remember, the diastolic pressure is why? Because of the aortic recoil. If aortic recoil is not there, what question will come? Diastolic, which is one is systolic pressure and then is the diastolic pressure in the blood pressure. The cause of diastolic pressure is because of aortic recoil or peripheral vascular resistance. Okay, aortic recoil or peripheral vascular resistance. Okay, talking about the pressure of the right ventricle, it is going to be 25/5, and in case of pulmonary trunk, the pressure is going to be 25/10. Let us mug it up very quickly. Remember, maximum pressure in the ventricle, left ventricle, 120/5. See the difference? Too much will be there. Then in the aorta, 120/80. In the right ventricle, you're having 25/5, and in the pulmonary trunk, you're having 25/10. Okay, they ask this in physiology. Last thing I want to talk about, few things about blood pressure hypertension is, remember, how do you differentiate in conditions of normal patient versus a hypertensive patient is, in a normal patient at the time of 4 to 6 a.m. you will have a nocturnal dip. This nocturnal dip is absent in a hypertensive patient. That is the main difference you need to know. Normal patient, you will see that the nocturnal dip is there around in the early morning, but this will not be there in case of a hypertensive patient. If I ask you what is the normal blood pressure, it is by 115/75. Remember, because of the new guidelines, 120/129 is also known as pre-hypertensive. If they will ask you what is the most common cause of hypertension, that is going to be idiopathic. Idiopathic is also known as essential hypertension, or also known as idiopathic hypertension. That is the most common cause. If they'll ask you what is the second most common cause of hypertension, that is going to be renal parenchymal disorders. In all groups, adult, child, or in case of elderly, the second most common after idiopathic is going to be renal parenchymal disorders. Now, hypertension causes target organ damage. Now you need to know what are the organs which hypertension gets involved. Basically all the organs. Talking about the heart, it is going to cause you left ventricular hypertrophy. Talking about the eyes, it is going to cause you focal attenuation of the arterioles. Talking about the kidney, it is going to cause your hypertensive nephropathy. Remember, hypertensive nephropathy can cause end-stage renal disease, and the value for end-stage renal disease is GFR less than 15 ml per minute. Okay, in the brain, it will cause stroke, and the most common site is going to be putamen. Remember, we talked about that in the earlier videos. Aorta, it is going to cause aortic dissection. What is the symptoms of aortic dissection? At the time of rest, you will have severe chest pain, which is usually in the interscapular area. Severe chest pain in the interscapular area. Okay. If you talk about the investigation of choice, in case of aortic dissection, it is going to be CT angio or TEE. Can you tell me what is the full form of TE? Because they have asked this in a question. If I'll answer you right now, it will be just a passive memory. If you learn, if you find it out, and then you comment below, I really request you to comment below, so that if other people are not finding it out, at least they will find it out that way. Okay. So please comment below what is the full form of TE. This is also an investigation of choice in case of aortic dissection. If another surgery question is, they'll ask you the most common cause of aortic dissection. Again, the answer is going to be hypertension. Okay. So for the last summary table, what I want you to know is what are the diastolic murmur, what are the systolic murmur, and what are the continuous murmur. Simple. What is diastolic? Whenever the blood flows from the atria to the ventricle, or when the blood flows from the aorta to the ventricle, are all your diastolic murmur. Whenever it is within the contraction time, which is during the ventricular contraction, if it is going up, if it is going side, that is going to be your systolic murmur. So remember, diastolic murmur, the first one which we talked about was your Carey-Coombs murmur during the mitral stenosis time in case of rheumatic heart disease. Austin Flint is a murmur that is seen as severe aortic regurgitation going from aorta to the ventricle. So that is Austin Flint murmur and your mitral stenosis. These are diastolic murmur. Systolic murmur can be divided into two parts. One is going to be ejection, just for a start, that is going to be PAS, pulmonic stenosis, aortic stenosis, and another condition that is your hypertrophic obstructive cardiomyopathy that has a subvalvular aortic stenosis. Remember, these are the ejection one. Whereas the pansystolic are the one which goes up, that is your mitral regurgitation, and the one which goes side, that is your ventricular septal defect. Talking about continuous one, which we talked about two conditions, that is patent ductus arteriosus and co-attraction of the aorta. These are the must-know things. If we want to talk about, each and single disease, it can take literally 2 hours for just one single disease. We need to know with respect to exam-oriented. This is what I studied for my exam, and I had got a great result. Okay, so this is all. Please make sure you read this FMG mantra. Comment below how did you write this lecture, and see you in the next slide.